Hi, my name is Dr. Rina Allawh. Welcome to Skin the Surface, a monthly segment where we address important topics related to your skin. This show is intended to serve as an educational resource for members of our community. Our hope is that we encourage you to take a more active role in your skin health. We do not provide any personal medical advice, so if you feel like any of the issues we discuss apply to you, and we hope that many of them do, we recommend that you consult with your board-certified dermatologist for more information. On today's episode, we will be discussing one of the most common types of cancer, skin cancer. Despite all of the great advancements in medicine today, why are the rates of skin cancer continuing to increase? To help me answer this, I'm joined by a member of our local community and a highly regarded dermatologist and dermatopathologist at Thomas Jefferson University, Dr. Jason Lee. Welcome, Dr. Jason Lee.
Well, thank you for having me, Rina.
So just to jump right into it, can you review the different types of skin cancer for our listeners?
Well, there are lots of types of skin cancers, but there are three cancers that we see most often, and they are basal cell carcinoma, which is the most common one that we see. Squamous cell carcinoma is another one. That's the second most common. And the third most common one is melanoma, invasive melanomas and melanoma in situ. By far, basal cell carcinoma are much more frequent. There are about nearly 5 million basal cell carcinomas a year, new basal cell carcinomas a year, whereas there are about 90,000 melanomas that we see a year. So basal cell carcinomas and squamous cell carcinoma account for many more cancers than melanomas.
And then who is at risk for developing these types of skin cancers?
So patients with certain phenotype or certain traits have a higher risk, and those people are ones that have very fair skin and they are unable to tan. So basically, those who get red rather than tanning, they are much higher risk for developing skin cancers. And so they also tend to have other traits like fair skin, and as well as blonde hair, red hair. They tend to have lots of freckles, and they tend to have more moles as well, and ones that are flat and dark. And so those are traits that gives you a higher risk of developing these cancers. But sun is not sun doesn't explain it all, but sun is the major risk factor, or sun exposure is the major risk factor.
And then I know you had mentioned melanoma. When counseling the patients about melanoma, in your experience, do you think that they usually come from a new mole, or do they arise from a pre-existing mole?
Well, I think in the 80s, there were studies that came out that there are moles that we needed to worry about, and partly because these patients were they were studied very closely, and they tend to have the patients who develop the melanomas tend to have these moles, and they've been called BK moles, dysplastic nevi, atypical nevi. And so the patients who are fair, that don't tan well, they're the ones who tend to have these nevi, and they have been looked at very closely by dermatologists. And over the years, they were biopsied, they were seen and monitored and biopsied. What we know now is that these nevi are they're markers for patients who develop melanoma, and that they are not necessarily precursors to melanoma. Initially, the notion was that these may be precursors, and many of these were biopsied and looked at. But they have, and many patients been demoled at times, but they didn't reduce the risk of developing melanoma. They actually are a phenotype or a marker for patients who can develop melanoma. And most moles are stable, and it's estimated about 10 to 20% of melanomas develop within existing moles.
Mm-hmm. And then do you, as a dermatologist and a dermatopathologist, when looking at slides and seeing patients in the office, are you seeing that there's more cases of melanoma from when you initially started as a dermatologist?
So definitely there has been increased incidence of melanoma. Every year it has increased. And so partly because the patients are being screened more frequently. And I think our society, American Academy of Dermatology, has done a good job to increase the awarenesses of melanomas. And so in contrast to in the 40s and 50s, when patients were diagnosed, they were sick, and the patients had bad outcome. Nowadays, we are diagnosing melanomas very early, and half the cases, are melanoma in situs, and the other half are invasive melanomas. And so we are catching them very early, and even the invasive melanomas, over 80% are stage 1 disease, which means it's also very thin and early. And they have good prognosis, and the survival rate is very high. And in fact, stage 1 disease overall has about 98% 5-year survival rate. And so, so we are detecting them very early, and patients are having good outcomes for the most part.
That's great. One of the things that I find that can be very helpful when seeing patients is the dermatoscope. And in 2010, a study published in the Journal of Academy of Dermatology found that a number of biopsies actually decreased by 38% after dermatologists gained a year of experience doing dermatoscopy. I know that you have a special interest and have done many lectures on dermatoscopy. How has it changed your practice?
Well, as you know, Rina, every provider who performs skin exam now has a dermatoscope, and so we were sort of slow to adopt. Australia and Europe, they adopted it much earlier than we did, and but now almost everyone uses a dermatoscope, and so it's a device that gives you a light source and 10x magnification, and so you can, just by those facts, you can visualize lesions better. The difference between just a magnifying glass and a light source and a dermatoscope is that it renders that dead skin layer translucent, so we can peek into the surface, viable surface layer of the skin much better with the dermatoscope. So most of us have a handheld one. In the earlier on, people use the contact dermatoscope, which has a liquid interface that makes that, the scale that come off your skin, that layer, the dead layer of the skin, translucent by the liquid interface. The new dermatoscopes is a polarized light that makes the cornified layer, dead layer, translucent. So a lot of people who use dermatoscopes, they feel if they don't have one, they feel naked without one because we're so used to using one. So the question is, does it have an impact on patient management? Well, all the studies that have come out from Australia and Europe, that's where most of the studies come from, then the answer is yes. They said it reduces biopsies of benign lesions and increases the sensitivity of diagnosing melanomas. In the United States, there haven't many studies that come out and said that's the case. I think it enables us to triage lesions better for sure. And as I indicated, that by far what we see in our office, in our practices, are basal cell carcinomas. And it may be that dermatoscopes have a higher impact on diagnosis and management of basal cell carcinomas rather than melanomas. I know there are studies that says, as you indicated, that it decreases the biopsies, but the number of biopsies performed by dermatologists and providers that examine skin care have not decreased, and in fact, it has increased dramatically over the last 10 years. And so the jury's sort of out. We still have to have an outcome study that really shows us that it has an impact on patient management. And there are very few studies that indicate it changes our patient management at this point.
Very interesting. And then, so if a patient comes in and they have a biopsy that's consistent with a skin cancer, I know it differs based on what type of skin cancer, but what is your general approach in treating skin cancers?
Well, so again, so the treatments, most of the definitive treatment for most skin cancers is excision after the biopsy has confirmed the diagnosis. And so, as I said, basal cell carcinoma are extremely common. And then, we have most surgeons who take care of the skin cancers. And for basal cell carcinomas, squamous cell carcinomas that are on anatomic sites where cosmetic issue, the cosmesis is a big issue, especially on the face and so on. Most surgeons take care of our skin cancers. The other sites that include, for example, genitalia, fingers, and areas where there's not a whole lot of skin to take, most surgeons are involved in the majority of those cases. Melanomas, and as I said, there are many melanoma in situ. Melanoma in situ meaning that it's just at the top layer of the skin where it has not become invasive. Those are also being managed by most surgeons, particularly when they're on the face as well. In Mohs surgery, the difference between Mohs surgery and excisions are that traditional excisions is that Mohs surgery, they map out where the lesion is by doing frozen sections in real time. And so they can sort of minimize taking the normal skin that's more normal skin than necessary. So surgery is the mainstay. And then there are other options for very thin skin cancers like superficial basal cell carcinoma. Sometimes we just shave the lesion and scrape the base a little bit. And there are also chemical treatments for options for these. And so your dermatologist has a variety of options to tackle these cancers, depending on the size, the anatomic site, and so on.
And then I'm sure you get this question a lot, Dr. Lee, but when patients ask you this, what can they look out for at home in terms of a skin cancer?
Yeah, so patients develop, as we age, we develop a lot of different things, and a lot of benign things as well. So sunspots or solar lentigines is a very common lesion, and that's one reason to use a sunscreen because it'll prevent some of these as we age. And they come in all kinds of sizes and color, and so typically they're tan and brown. And so on the face, particularly, if they have an atypical clinical appearance, they can simulate melanoma, thin melanomas, and so they're often biopsied. And so what you should look for, since as we age, we should be looking for things that are new. Typically, if you're age 40 and older, you're not going to get a whole lot of new moles at that age. Most moles are acquired in your teens and 20s and early 30s, and when you're born with them. But as we age, we don't get as many. So any brown spots that come and that tends to grow, those are the ones we should watch out for. And it's also a good idea, since we can't see our back of the legs and so on, we don't tend not to look at those areas. Have a partner or somebody also look at for anything new. So anything new is something that we should look out for. That's for melanomas that are pigmented. And then for basal cell carcinomas, we are diagnosing them earlier and earlier as well. And so, typical lesion is described as pearly and translucent, but those are very well-developed lesions. And what you should look out for, I tell my patients, if you have a pimple on your face that's not healing for 2 or 3 months, and particularly if you had a history of skin cancer, those are usually not going to be pimples. So things that don't heal, that are red and persistent for 2 or 3 months, they should be looked at by a dermatologist, and they often are basal cell carcinomas than pimples.
And then how often should someone see a dermatologist, and how frequently should they see a dermatologist?
Now that's a question we always get, and that really depends on the risk factors. And so someone who has, dark skin, they don't need to come in for a yearly skin exam. That's poor use of resources. And so we should really be targeting higher risk individuals. And who are they? As we talked about, those are fair-skinned individuals that don't tan well, those who've had history of skin cancers, those who have history of melanomas particularly. And so typical patient is once a year a full body skin exam. I also ask them to do an exam at home as well, as I said, and if they particular areas they can't see, have a partner or spouse look at their back in areas they can't see. So at least once during the year and once a year with a dermatologist. If you had a history of melanoma or you've had recent history of melanoma, that's a little different. They come more frequently, and so they come every 3 to 6 months, depending on what your dermatologist recommend. But it's more frequent in the first couple of years, and so and then after 5 years, it goes to baseline for those patients who have melanoma.
Is there any additional information for listeners out there who are concerned about skin cancer, concerned that they may have a skin cancer that you think they should know about?
Well, I think reaching out to now it's easy to reach out to dermatologists, and as we have telehealth, I have patients who take photos, and so I ask the patients to take good photos, and so it's a good time to learn how to take photos of yourself and individual lesions in good lighting. And most of us has electronic medical records where they can log in and send images, and so anything new, anything different, they can do that and send to us, and so that we can easily assess these lesions, and so if you're worried about a possible skin cancer, and particularly if you had ones before, you really need to reach out to us and have it assessed. It's better always in real time when we can see you, but any concerns, just reach out to us. And as I said, it's much easier now with all the different technologies that's available.
Mm-hmm. And now with coronavirus, increasingly important to take advantage of the telehealth services like you mentioned. Well, thank you so much, Dr. Lee, for joining us. Now that you all know all there is to know about skin cancer and what we can do at home to minimize our risk of developing skin cancer. On our next segment, we will discuss sun protective strategies that have been shown to lower your risk of developing skin cancer. And we will also dive into the very heated debate around sunscreen and sunscreen absorption that has been recently been in the news. That's all we have for today. Thanks for joining in today's discussion about your skin. We hope that you learned something new. If you like what you heard today and you want to learn more about any additional COVID-19 updates from a skin perspective, check out our latest podcast at skinthesurfacepod.com. We're also available to listen to on iTunes and Spotify. And you can continue to send us updates, subscribe, and listen. See you next time, and then stay home, and most importantly,